So this is a presentation of a case whereby the patient says that there is clicking of the knee. And where can clicking comes from? Clicking can come from the patella moving on the femur. Okay, it can also come from a meniscoid clicking, or it can come from the tibial on femoral clunking, which is the shiftings and so forth. Okay, but let's just say we have a positive patellofemoral syndrome. Therefore, Thomas test was positive and all that. My question now is, how are you assessing the patellofemoral joint movements? So if we look at the patella, it sits in a groove here. Okay, it's more in this view here. This is also called the sunshine view. We should have the femoral groove around here, and we should have a continuity of the patella moving on it this way. Question is, how are you assessing the ability of this particular structure to glide along this groove as it goes into further bending, and how accurate are you finding some of the structures? So one other few informations you have to know is, I'm not asking for pain reproduction of the joint. I'm not asking for you to palpate the corners. I'm not asking you to compress and glide. I'm only asking for, how does the patella move? So the patella moves, it starts here and it will go into a C-shaped curve like that. Okay. How do we know that there's a C-shaped curve? Because this particular curve here has to follow this particular structure. So as the further bend into it, this particular curve here would then be in contact with your patella. So therefore it forms a C curve. Okay. Because the kneecap goes in a C curve here, if your assessment of patellar mobility that you're talking about, you are moving it down and up, is that the right way of assessing it? To look for the mobility of how it moves. Okay, you have to then consider whether are we pulling it down this way, or we're pushing it up this way, or are we doing it in this way. Okay, I preferentially would do this way to this corner here. Okay, which in my mind I am checking for the articulation of this part of the kneecap alongside with this part of the kneecap at the end ranges of the kneecap fully bending. Okay, so it's more or less in a diagonal. Or I can do this diagonal, which I rarely do, which then I'll be looking for this part of the continuity and this part of the continuity. Okay, now the next part of it is, we have the medial and lateral. So we know that it goes in a C curve here. Some C's are relatively shorter curve angulation, or some C's are wider in the angulations. That is not determined by you, that's determined by the condylar curve here and also the ligaments around the sides here. So it is also important to compare right and left. Maybe they have a rupture of this particular structure here that led to a lot more give when you're pushing it this way and this way. Okay, we do have patients with patellar dislocation that the give is a lot more, and most of the time the groove here is a lot more shallow. When the groove is deep, the kneecap sits snugly inside here. It will have minimal movement. The other part that you need to understand is the tiltings. So if we have the kneecap here, we are trying to push the kneecap this way. Okay, it is only assessing the glide between this structure here and this structure here. But what if we're looking at the envelope that sits around this way, which is your ITB on this end, your MCL, your capsule, the knee capsule that runs up. So we might need to be moving the kneecap, pushing it this way, which can further taut this area already. Then we have to tilt it a little bit more to feel for the gapping between this area here, and we also have to push it this way and to feel for the gapping this area here for this part. After having assessing on all this, then you can make a good sort of judgment whether the kneecap is moving in a normative curve here or not, or the kneecap is actually going straight up like this. Okay, if the kneecap goes straight up like this, that means certain areas would have a rubbing more than certain areas here. Any questions? It is almost impossible for you to cup the kneecap and bend the patient and expect to feel this C curve. But this C curve is normal, and your job is to restore a person's movement as close to normal. So this particular scenario we see quite a lot, whereby a patient is very dominant to the quads, and it really tense up the quads, and the kneecap basically is just fixated here, and it doesn't glide and rotate in this particular manner. It's not stuck. It can work as a nice pivot. So kneecap is a sesamoid bone. Sesamoid bones are designed for mechanical advantage. So if without the kneecap, it will run straight like this. And then for it to straighten out, there is an area of inefficiency. So when there's a sesamoid bone available here, which then serves as a pulley. So therefore, the person can pull along this pulley here, making the knee straighten out a lot more efficiently. Now there are people who then just purely use the quads to articulate that way. Therefore, the pulley system is working well, but the bearing of the pulley will then take a lot of load, and they get arthritic changes on the kneecap, and they will have a lot of tension around here.